Just coming up here to start streaming, Sean. Okay. Well, good morning, everybody, or good afternoon, wherever you may be. I'm Jay Remley. I'm on the board of directors here at the Lupus Foundation, and welcome to Office Hours with Dr. Parsa. Dr. Parsa, it's great to see you again.
Good morning, Jay.
Good morning. It's been a few months, and it's great to see you again. We obviously, over the summer at the Lupus Foundation, we had our patient conferences in July, August, and September. And so we're back here on schedule with Dr. Parsa, and we have a couple topics that have come in since the last time we had our office hours with Dr. Parsa. And obviously, there have been a lot of developments over the summer with COVID and some new booster approvals by the FDA, as well as some new antibodies that have come out, and it's become always top of mind for our lupus patient community with COVID and with it impacting the immune system. And so we wanted to tee up a few topics here today for everybody. And as we're streaming here live on our Lupus Foundation Facebook channel, also feel free to add comments. We have the team monitoring our Facebook Live, so feel free to add comments or questions, and we'll try to answer those live, here. And we'll try to make this in the next, 30 minutes. We'll try to get through the key topics here in 30 minutes with Dr. Parsa. His time is very precious, and we always appreciate him taking the time and spending it with us. So why don't we jump in here, Dr. Parsa? So, um, obviously, lupus patients with, a compromised immune system, there's always developments and the latest coming out with the vaccines and antibodies and so forth. And I understand that there's a new antibody that's come out, right, to help patients who get COVID, whether they have had the vaccine or not have the vaccine, which can significantly, improve the severity of COVID, of getting COVID. And wanted to ask you here and get your thoughts. If you are anybody in particular, but in this case a lupus patient, maybe they had the vaccine, maybe they haven't had the vaccine and they get COVID. What are some of the new developments you're seeing out in your practice that is now helping COVID patients or patients that get COVID work through it better than even what we had in tools that you had at your disposal even just 6 months ago?
Thank you so much again, Jay, for hosting, me and then having, the opportunity to talk to our wonderful audiences here. The great news from the last times and last sessions that we were talking is just, most of the population has been vaccinated, and we see huge improvement, as far as the protection, the decrease in the number of the patient being affected, the hospital admission, ICU admission, and of course the mortality and morbidity from the COVID, which is a great news. And on top of that, we have another great news is that the beginning of the monoclonal antibody that being produced for the patient who either the vaccination didn't stimulate the immune system enough and strong enough to protect the body, or for the people who, for whatever reason, they weren't able to have the vaccination, didn't believe to the vaccination, or have severe reaction to vaccination. So we have a new hope that is decreasing the morbidity and mortality of this patient, especially for the patient. COVID, as we talk, in the most cases, not causing any severe symptom, maybe 70-80% of the patient not having any problem. They usually just get the COVID, and with the simple, measures, staying at home and, working on the immune system, taking all the good supplements, they will recover. There is a between, 20 to 30% of the patient might get moderate to severe COVID. That is always a concern because that could end up, going to the hospital or just being admitted to the ICU or just their condition, clinical condition getting worse. With the vaccination that we had, these numbers are all down. And now by having the monoclonal antibody for this group of patients, if we're starting it with the first early symptom, we can completely reducing the mortality and morbidity of this patient. That is a great news. The people who are eligible to getting it, there is a table was published by the UpToDate, are the people who are just elderly, the people who are immunocompromised, the people with the diabetes, chronic kidney disease, cancer patients, or patients that for whatever reason they weren't able to get the vaccine, or they got the vaccine but they didn't develop the antibody or proper immune response to it. So we have a backup plan, and that backup treatment would be great to just protecting the patients.
That's great. And so patients that are, interested in that, Sean, is it something to talk to their primary care physician or their rheumatologist about if they are seeing signs of COVID? Because to your point, it's always best to catch it early. But it sounds like this treatment's fairly new, and not maybe everyone would be eligible for it. I'm assuming most lupus patients, of course, with compromised immune systems probably would fall into that category to be eligible. But what should the patient ask for or talk to their doctor about that?
So we usually consider this treatment for the people who are having or started having, symptom or the signs that's suggesting of the severe COVID. For example, you might have the lupus and you get COVID, but you're not having any severe symptoms, means like a severe shortness of breath or the saturation just going less than 92 or 93%. You don't need this treatment. The home treatment and the simple remedies that we have at treatment, like supplements and rest and isolation, is enough. But if you started having, severe symptom, including, like having the shortness of breath, started having, severe chest pain, or when you're monitoring your saturation start going down, this is a time that you would just obviously you need to go seek for the medical treatment. And once you get to the ER, they would evaluate you, and if it is in that center, there would be the antibody available. They can offer it to you. So not necessarily every single patient with the COVID needs this treatment, but if we have any indication that the patient starts getting severe symptoms, saturation going down, started having shortness of breath, which mandates to go to the emergency room, then there is a treatment available. So that is a great hope. That's a great thing, because we know. So before this monoclonal antibody, we didn't have any effective treatment available. Remdesivir was helpful. Dexamethasone, which is a steroid, was helpful, but was not as effective as this monoclonal antibody. But with this monoclonal antibody, now we have the hope that if we get the severe symptom, including the lupus patient or whoever that the immune system is not working the best, not being vaccinated, or for whatever reason, because of the risk factor, obesity, chronic kidney disease, diabetes, cancer, their immune system is not the best, and they started showing the signs of the bad symptoms, means the saturation dropping, shortness of breath is coming, then we have a treatment that would be able to control over the disease. And we can call it, it's not a definite cure, but it would just help dramatically with the numbers of the patients would be ending up to the ICU or dying because of the COVID, which is a great thing that we have.
Okay, that sounds great. Thanks for
There's
the.
actually two other antiviral medication is being studied now outside the United States, and they're doing some research on it. It's not completely to the final phase of it, but again, for now, the monoclonal antibody is a great hope that we have, and we can be very. The more studies and the more numbers are going to be published soon. But so far the result has been very great. With this antibody preventing not ending up in the ICU or dying because of COVID.
Mm-hmm. Okay. Well, that's great. That's a great update, and thank you, Sean. Hopefully, that's helpful to our audience out there. And it's great to see the progress here as we continue to learn and improve the treatments for COVID. So let me shift gears a little bit. We've had a few questions that have come in, here live, Sean, and I always appreciate you taking these questions live. They're never easy because you never know what they're going to be, but always appreciate you willing to take the live questions here. Um, so this first question is, looks like it's a patient that's taking or is on Benlysta, and the question is, can I take vitamin C, D, and zinc? So vitamin C, vitamin D, and zinc while taking Benlysta.
Of course. The Benlysta just does, its job. We have to just, the immune system is coming, and the proper function of the immune system coming from so many facts: genetics, the nutritional status, and, we need to just make sure that we're getting enough protein. Proteins are the building blocks for the antibody and for the function of the cell-mediated immunity. So for the body being able to just fight against the COVID, then having the proper nutrition is essential. Since again the core mechanism of the defending against all the infection, including the COVID, is just producing antibody. Antibody is nothing but protein, and in order to make the protein, we need to have a good nutrition. Zinc is a coenzyme of so many things, including with the immune system and the reactions in the body. So definitely we need to have sufficient amount of the zinc. And sometimes, because of the nutrition that what we're getting, we don't have a lot of storage for the zinc and some other water soluble vitamins. So the body needs to get all these vitamins and these micro elements or trace elements on a daily basis. For that reason, I'm always recommending my patients to take some multivitamin plus minerals. And the rationale behind it is because, we don't have a storage for all of this in the body. So we need to have it on a daily basis in our food. And sometimes it's not practical to just have all of these trace elements in every single day food. So definitely we need to have the proper amount of the zinc. We recommend to take at least 25 to 50 milligram of the zinc daily. If you get the disease or just got affected by the disease, we need even extra amount of the zinc to help with the immune system. Yes. And the vitamin D, as we talked in the previous sessions, is a general pandemic, in the body, the deficiency of the vitamin D. We don't know what the exact mechanism of the deficiency. And we highly recommend to talk to your primary physician to check your vitamin D level in your annual physical exam, and to know how low it is and try to treat it. If you don't know it, or you've just got COVID, it's recommended to take 5,000, vitamin D daily, and zinc and other good, elements, and vitamin C, the three elements that is helping with the immune system and immunity and immune modulation.
Perfect. Well, thank you, Sean. So to summarize, it sounds like it is okay to take the supplements if you're on Benlysta. Obviously, always, touch base with your, physician, to make sure. But just it just sounds like summarizing what you had just mentioned. So 20, on the zinc, 25 to 50 milligrams per day is a normal level. Vitamin D, 5,000, per day, but check with your physician. I actually had my blood work done and checking my vitamin D. I've been taking that ever since you recommended it in the beginning of COVID. And same thing with vitamin C. Vitamin C is what is that? Around 1,000 milligrams a day is
Plus
kind of
milligram
recommended.
daily. That is
Okay.
recommended. That is good for the immune system. Is good for the wound. Vitamin C and zinc, in so many studies showing with making a huge differences with the outcome of the patients, of the wound, of chronic condition, the patient in the hospital, the patient who are immune deficient and fighting with some kind of cancers or infectious in the body, infectious agents in the body. They're very helpful. So we highly recommend to be added specifically to the regimen that you're taking daily, even if you're taking in the multivitamin, because multivitamin doesn't have, because a lot of patients are asking, I'm taking multivitamin, do I need to take the vitamin D? Unfortunately, multivitamin, most of the multivitamin, formula doesn't have more than 800 units of the vitamin D, and
Mhm.
that's not enough. And most of the people are deficient, so they need at least 5,000 to 10,000 daily if they're deficient. So if you don't know the level of the vitamin D, it's completely safe to take 5,000. It's not going to overdose it or anything, but as you mentioned, it's recommended to talk to the primary physician, make sure that would be part of the lab they're checking once a year, at least to know what the baseline is, and then make sure that monitoring it to just know it's in a good level. Uh, uh, um, and vitamin D is related to so many great function in the body. The people with the asthma, when they're taking vitamin D, their vitamin D is more stable. The people with the depression, the people with the immune deficiency, with the autoimmune disease, with the cancer, basically all of this studies showing that when you're just replacing the vitamin D, it would make a huge differences. And as we talked last time, if it's so, vitamin D's normal range in the blood is between 30 to 100. If your number is 31, we shouldn't be very happy about it. It's very low normal. It just the minimum for the bone resorption and the calcium resorption from the intestine. The immunomodulation property of the vitamin D starts when the level goes above the 50. The
Mhm.
65 is the ideal dosage. So make sure that your vitamin D going above 50, close to the 60, 70, that range. We know in that range, the immunomodulation is perfect in the body. So,
That sounds good. Yeah, I was going to ask that question because I know you mentioned it before. And when I had just recently had my blood work done, my vitamin D was 61. And I remember
oh,
you saying you
awesome.
wanted above 50,
That is
really for the vitamin D to kind of really be a booster for your immune system, if you will. Above 50, it's, positively impacting your immune system. So I was in
perfect.
that range, not quite to your 65, but I'm butting up against that 65 there at 61. So and I've been taking 5,000 a day, for over a year now since the beginning of COVID. So thank you for that. And great question, by our audience there on vitamin C, D, and zinc while taking Benlysta. So this next question, Dr. Parsa, is coming back to, the COVID vaccine. So we have a patient here that is obviously on several medications for their lupus, 10 milligrams of prednisone, 200 milligrams of hydroxychloroquine or Plaquenil, and a couple other has taken some injections also as part of it. Rituximab, it looks like, as an injection treatment, and is recovering and in remission or working, through their flare, I should say, not in remission yet. And so the question is it safe to get the COVID vaccine?
Yes. Actually, we highly recommend for these group of patients because they're at the higher risk because of the immune system to get the vaccine. Maybe it would be the CDC hasn't advised to check the antibody after the vaccination, but I believe that per case we can check the antibody to see what the body's response and the immune reaction happening after the 2 dosage of the vaccine. So to make sure that they're being fully immune against it, because sometimes we need the third. We recommend to third vaccination for this group of patients to get their booster, and even for the first dose, we recommend to have the third dosage of the vaccine until, because we know by the number. So what is the purpose of having the 2 dose instead of the 1 dose? Studies showing in the preliminary phase 1 and 2 of the preparation of the vaccine showed that when you just give 1 dose of the vaccine, there is a smaller number of the people would be immune and having the proper, immune response to the vaccine. When you give the second dosage, like with the mRNA vaccine, like a Pfizer and Moderna, 95% of the population would get the immune system that is needed. When you have the immune system deficiency, like a lupus, then that chance that you would be more highly to be in that 5% that you're not responding to with the 2 dosage of the vaccine. For this group of patients, we recommend the 3rd dosage also given to the patient to just probably bring this from 95 to 97, 98%. So getting it closer to the 100%. And based on the clinical condition, your physician might decide to check your antibody level after the 3rd dosage to make sure that you're having the the antibody reaction to the vaccine. And if it's not, then we know that you're prone, and you might be, if you get exposure to someone with the COVID, or you get the COVID, then you're among those people that you're eligible to get the monoclonal antibody. Because
Okay.
for whatever reason your immune system is not responding, we want to just provide that antibody. If your body is not making it, we're giving it from outside to your body to just be able to defend yourself. So
If your body's not making the antibody, if you will, for COVID, yeah, on its own, yeah, through the vaccine.
that is,
Okay. Well, so interesting follow up here, and I know these. We have a live question coming through our Facebook live channel here. It's the question on that last point a little bit is why do some rheumatologists not advise their SLE patients to have the COVID vaccine? And I know opinions vary, and physicians have their experiences and so forth too. So not to not to put you on the spot here, but just a live question, coming through. Any reasons that you might be aware of, Dr. Parsa, why a rheumatologist would not advise an SLE patient to get the vaccine?
I believe that we shouldn't, as a physician, to just have any personal opinion, because it's not sufficient data for any physician to be able to make any generalized comment about anything. The Bible of Medicine is up to date, which is a website that would be every 3 months, with the COVID every day, but with the other diseases every 3 months would be updated and give us, like the guidelines based on the best evidences available in the studies. So far, what we know is we recommend with all the patients with the immune suppression, immune disorder, immune suppression disease, medication, or if they're immunosuppressed, like lupus patient, cancer patient, the people with born with the immune deficiencies, they're all recommended to get the vaccine. The response to the vaccine is not going to be optimal for sure, because we know that there is a problem in the immune system not properly involved with the factors of the vaccine and responding to it, properly. So, but we don't have the only contraindication of not getting the vaccine is severe reaction to the vaccine in the prior vaccine. Even with those patients, we changed the vaccine. For example, if you got the mRNA and you got severe reaction, we consider to get another version of the vaccine that you might not be having an allergic reaction. So uh, based on the guideline, there is no such a thing as that not getting any vaccine unless there is a severe reaction to the vaccine. Then I had a patient that just came and said that he had, some other live vaccine, and he had a very bad encephalitis ending up in the ICU. So those conditions that is very rare, 1 out of 10,000, 1 out of 100,000, severe reaction to the vaccine is the only contraindication to the vaccine. Otherwise, it's highly recommended to get the vaccine, even though we know that, the immunosuppressed patient might not making antibody with the 2nd or even 3rd dosage of the vaccine. And then for that purpose, we have the monoclonal antibody available to be giving it to them to be able to protecting them. But no, there is no such a thing of not getting vaccine unless there is severe reaction in the previous studies. And even with those patients, we refer them to the immunologist to see if there is any way we can give them some steroid or something to not letting them to have anaphylactic reaction or bad reaction to the vaccine. There is a possibility with some medication, those adverse reaction would be prevented. But yeah, definitely we wanted everyone with the bad immune system, low immune system, cancer, autoimmune disease, get vaccinated. Even the third dose of the vaccine is recommended for them. In some cases, we also recommend to check if the antibody being produced. If not, then we know this patient is vulnerable. In that case, that they're getting exposure or getting the COVID, they're eligible to get the monoclonal antibody.
That's a great point. Even after the vaccine, especially the second dose, get tested to see how your body is reacting and your level of the antibody, that you're producing or that you have. So
In the
along
rare,
those lines,
not for the general population, but in the rare cases that we know this patient has bad immune
yeah.
system or severe reaction, specifically and individually, we can check the antibody. You're right.
Mhm. Absolutely. Okay, great. Well, along those lines, another question came in after 2 doses of COVID vaccine. I had an autoimmune reaction with tongue rashes were the symptoms. Um, any thoughts on was that a reaction from maybe the second dose of the vaccine? With the patients, basically, it looks like the symptom, after the second vaccine started to develop tongue rashes.
One of the interesting things about the COVID and the vaccination and everything, a lot of people after the COVID or after the vaccination started having some immunological reaction. I believe that most of these patients have some underlying autoimmune disease that they didn't know before. And now by getting the vaccine or getting the COVID, it just, manifests itself that, or letting that, Pandora box to be opened. So we have also reaction to the vaccine. That is part of it is the autoimmune. We know that, but I know some patients that they didn't know that they have some, for example, Behçet syndrome, or they had lupus. And once they get the vaccine, or when they got COVID, they started having joint pain. And when at first they thought it's just part of a disease, but later they figured it was an autoimmune disease that they had, which was being revealed by having the COVID vaccine or the COVID infection. We have to make sure. So, what I would recommend, if you have any reaction that is not listed as the general, reaction to the COVID, I would highly recommend to talk to your doctor, and maybe they need to just do some more tests, because there might be some underlying disease that was there, but it wasn't manifested before this condition, or it was very not, being very silent and latent phase. Now with the starting of the COVID or the vaccine, it showed itself.
Yeah.
So we have to make sure it's not a disease that they already had in their gene. It was silent. Now it's being like any other autoimmune disease. We know that a lot of people with the Crohn and ulcerative colitis, the first time they would start having a symptom is when they have a nervous breakdown. The nervous breakdown is not the cause. It's a factor that that disease is becoming apparent, and it's just
Mhm.
coming. So it was silent before. Now it's just showing up because the immune system being stimulated. So we have to make sure that this is not one of those cases that there was an autoimmune disease. It was silent. It was underlying. It wasn't manifested itself up to this point. Now they got the COVID, they got the vaccine, and now they have weird reaction or strange reaction that is not being listed in the vaccination, side effect. Then definitely they need to check, make sure they don't have that underlying disease. That rash on the tongue could be the manifestation of the Behçet syndrome.
Yeah.
Behçet, one of the other autoimmune disease that manifests itself with the genital and the oral, ulcer. And then there is a test for it. We call it pathergy test. So I will highly recommend to talk to the primary physician to get a referral to the rheumatologist and let them to do all the proper tests for the Behçet syndrome and treat the Behçet. And it was the vaccine or the COVID wasn't the cause, was the exacerbating factor to show that underlying disease showing it itself.
hmm Actually, it was come through. So is the Behçet's disease or syndrome. I guess it's also called Silk Road uh, disease that actually was maybe it was there in the genes but dormant or not active, and something with the COVID, activated the autoimmune, disease, Bessett's disease. So
If it wasn't the COVID, would be another incident future would just making it coming to the surface.
yeah, exactly. Okay. Well, great. Thank you for always taking those questions live, Dr. Parsa. I
So
know it's never easy getting questions on the fly like that, but as always, you're great responses, great answers, and thank you for that. I know we're coming up on the half hour here, and we try to value your precious time and keeping us to 30 minutes. I don't see any other questions coming through our Facebook Live chat, but I would like to close on a couple points. At the Lupus Foundation, we're always, working with our patient community as well as the pharmaceutical community, research community. We've had some great strides. We worked very closely with GSK and Benlysta, a decade ago, working through the trials, most recently with AstraZeneca. AstraZeneca just recently announced a new therapy for lupus called Sifnelo, really for adult patients with moderate to severe, SLE. And I think we talked earlier, just before this summer, about Urenia, who came out with Lucinis, right, for lupus nephritis. And all of these, it's great. I mean, it's taken us 40 to 50 years, to come out with any drugs and therapies for lupus patients. And we're starting to see more and more activity and treatments, coming out. So a huge thank you for those lupus warriors out there that are working with us, and us working with the pharmaceutical and research community on these clinical trials to speed up, getting more therapies, out there into the lupus community. So huge thank you. We'll talk more about both of those on the next office hours with Dr. Parsa, but wanted to tee those up. And just our understanding is we're very involved with the Lupus Foundation here with AstraZeneca and Sifnelo. We've been involved in the clinical trials. We're actually involved in working with them and getting the first few hundred kits out to lupus patients. So stay tuned on that. The goal here would be we'll give you an update and where we're at with both of those with Dr. Parsa on our next office hours with Dr. Parsa. So with that, I want to thank you again, Dr. Parsa, for joining us. Thank you for all the lupus warriors out there tuning in. And we look forward to seeing you on the next office hours with Dr. Parsa. And as always, just reach out to us at lfnc.org. Email us, give us a phone call. Any questions that come up, we can get those to Dr. Parsa. In the meantime, we don't have to wait for the next office hours and try to get your response back through our team at the Lupus Foundation. So with that, Dr. Parsa, thank you so much. Have a wonderful remainder of your Saturday and weekend here, and wishing you a happy Thanksgiving as well here as we're coming up on Thanksgiving week.
Happy Thanksgiving to you and all our wonderful audiences. And thank you for hosting us. You've been very great and very helpful for the community. Thank you, Jay.
You bet. Thank you. Thank you, everybody. And we'll see you on the next office hours with Dr. Parsa. Stay tuned and watch for our next one on our website. All right. Bye-bye.
Have a good night.